Of menstrual cycle. Menstruation is the end point in a series of events which begins in the cerebral cortex and hypothalamus and ends in the uterus in the hypothalamo-pituitary ovarian uterine axis. Any break in this axis creates menstrual problems. The various types of menstrual irregularities are amenorrhea. It indicates absence of menstruation. It is a symptom and not a disease entity. Oligomenorrhea denotes infrequent and irregularly timed episodes of bleeding, usually occurring at intervals more than 35 days. Polymenorrhea denotes frequent episode of menstruation occurring at intervals of 21 days or lesser. Menorrhagia denotes regularly timed episodes of bleeding which are excessive in amount greater than 80 ml or duration of flow greater than 5 days duration. Metrorrhagia refer to irregularly timed episodes of bleeding superimposed on normal cyclical bleeding. Menometrorrhagia means excessive and prolonged bleeding that occurs at irregularly timed and frequent intervals. Hypomenorrhea refers to regularly timed but scanty episodes of bleeding. Intermenstrual bleeding refers to bleeding, not usually excessive, that occurs between the otherwise normal menstrual cycles. Precocious menstruation denotes occurrence of menstruation before the age of 10 years. Postcoital bleeding denotes vaginal bleeding after sexual intercourse. Heavy menstrual bleeding. The term heavy menstrual bleeding is defined as excessive blood loss interfering with physical, social, emotional, or material quality of the life. It is generally caused by conditions affecting the uterus, vascularity, rather than any disturbance of the function of HPO axis. Whenever uterine endometrial surface is enlarged, the bleeding surface is increased, contributing to excessive bleeding. Such conditions include uterine fibroid, adenomyosis, uterine polyp, myohyperplasia, endometrial hyperplasia. HMB is also seen in women with increased uterine vascularity such as chronic pelvic inflammatory disease or pelvic endometriosis. Uterus is often retroverted in position with restricted mobility. Uterus is bulky and congested. Presence of IUCD often leads to heavy and prolonged bleeding. Lastly, menorrhagia may be a result of bleeding disorders like van Willebrand disease or an AV aneurysm. Normal menstrual blood loss is 50 to 80 ml and does not exceed 100 ml. In menorrhagia, the menstrual cycle is unaltered, but the duration and quantity of the menstrual loss are increased. Menorrhagia is essentially a symptom and not in itself a disease. It affects 20 to 30% of women at some time or other, with significant adverse effects on the quality of life in terms of anemia, cost of sanitary pad, interference with the day-to-day activities. Oligomenorrhea. The pattern of menstruation extends to cycle length exceeding 35 days without impairment of their fertility. This is compatible with normal reproductive capacity within limits of its infrequent ovulation, so it requires no treatment. However, if the cycles are very erratic and infrequent, medical attention is called for. Amenorrhea is often continuum of the oligomenorrhea. This condition is often encountered in women at the extremes of reproductive life and in some lactating women. Other causes are genital tuberculosis, polycystic ovarian disease, hypomenorrhea. In some women, menstruation lasts only for 1 to 2 days. The blood loss is so scanty that she may need a change of just 1 to 2 sanitary pads. Scanty menses, which is otherwise regular, may not be pathological because its regularity presupposes a normal HPO relationship. In these women, uterine end organ may be at the fault. A small hypoplastic uterus, genital tuberculosis, partial Asherman syndrome also cause hypomenorrhea and need investigation. Oral combined pills also cause hypomenorrhea. Scanty periods may precede menopause. Polymenorrhea or epimenorrhea. Shortened periods. Menorrhagia often goes hand in hand with this complaint. It is more frequent in adolescent girl and perimenopausal women. Etiology exactly is not known. Most of the women, the follicular phase of the cycle is accelerated, resulting in shorter cycles. Ovaries often appear hyperemic and may contain hemorrhagic follicle. Myohyperplasia of the uterus is common accompaniment. Lining endometrium is generally of normal thickness. However, in women suffering from polymenorrhagia, the lining endometrium may appear thickened. The cause of ovarian overactivity seems to be a result of disturbed endocrine axis. Metrorrhagia. The term it's intermenstrual bleeding is used to define any cyclic bleeding from the genital tract. The term should be restricted to bleeding arising from the uterus only. Bleeding may be intermittent or continuous. It is superimposed on a normal menstrual cycle. Intermenstrual bleeding may be physiological, occurring at the time of ovulation when hormonal changes triggering ovulation take place. These women complain of mid-menstrual pain, Mitchell smudge lasting from a few hours to one day. A profuse, sticky discharge, intermittent cramping pain of short duration. These episodes coincide with ovulation, but this fact can be confirmed by basal body temperature changes sonographically. A few months of combined OC pills will cure the ovulation bleed. Pap smear examination should be obtained. Diagnostic hysteroscopy, endometrial curettage for histopathological study of the endometrial tissue are important. Oligomenorrhea, cycle length greater than 35 to 38 days. Polymenorrhea, cycle length less than 24 to 21 days. Menorrhagia, increased cyclical menstrual flow at duration of regular cycles. Menorrhea, scanty bleeding, shorter days of bleeding. Metrorrhagia, irregular bleeding in between the cycles. Menometrorrhagia, increased menstrual flow as well as irregular bleeding between the cycles. Dysmenorrhea, it is defined as the cramping pain accompanying menstruation. It can be of various etiologies. Primary dysmenorrhea refers to the one that is not associated with any identifiable pelvic pathology. It is now clear that the pathogenesis of the pain is attributed to biochemical derangement. It affects more than 50% post-pubertal women in the age group of 18 to 25 years with ovulatory cycles. Secondary dysmenorrhea refers to the one associated with presence of organic pelvic pathology like fibroid, adenomyosis, PID, endometriosis. Unilateral dysmenorrhea occurs in rudimentary horn of the bicornuate uterus. It is also seen in some women wearing IUCD and in cases of cervical stenosis. Varieties. Dysmenorrhea can be three clinical varieties. Spasmodic dysmenorrhea is the most prevalent one and manifests as cramping pain, generally most pronounced on the first and second day of menstruation. Congestive dysmenorrhea manifests as increasing pelvic discomfort and pelvic pain a few days before the start of menses. Thereafter, the patient rapidly experiences relief in the symptoms. The varieties commonly seen in PID, IUCD wearer, pelvic endometriosis, and fibroid. It is also experienced by women having varicosity in the pelvic vein. Membranous dysmenorrhea is a special group in which the endometrium is shed as a cast at the time of menstruation. The passage of cast is accompanied by painful uterine cramp. It is a rare variety. Etiology of the pain. Spasmodic pain is attributed to myometrial contraction due to increased prostaglandin F2 alpha secreted under the progesterone effect. Increased peristaltic action is seen in the subendometrial zone on ultrasound scan. This causes myometrial activity. The pelvic venous congestion, as recognized on Doppler ultrasound, explain congestive dysmenorrhea. A relief from dysmenorrhea following cervical dilatation, vaginal delivery, is attributed to damage to sympathetic nerves around the cervix. Vasopressin, by increasing PGF2 alpha secretion in primary dysmenorrhea, is also held responsible. Similarly, endothelin, by increasing PGF2 alpha, contributes to dysmenorrhea. The flowchart here shows the generation of pain mechanism. Corpus luteum, which regresses before regression, produces the progesterone, which causes the menstrual flow. Increase in prostaglandin, endoperoxides, and metabolites leads to increased myometrial contraction, which causes reduced blood flow, leading to ischemia. This causes the pain due to increased uterine activity, uterine ischemia, sensitization of nerve terminals to the prostaglandin and endoperoxidase. Clinical features include primary dysmenorrhea is widely prevalent. More than 50% of teenagers, 30 to 50% menstruating women suffer from varying degree of discomfort. Its prevalence is higher among more intelligent, sensitive working class. Women. Both local systemic symptoms are apparently due to the rise of increased levels of prostaglandins in the menstrual fluid. This results in uterine cramping, nausea, vomiting, backache, diarrhea, giddiness, syncope, fainting. It is also responsible for the highest incidence of absenteeism, resulting in work loss hours and economic loss. Primary dysmenorrhea occurs in ovulatory cycles, hence it appears a few years after menarche with at least 6 to 12 months of painless period. It is most intense on the first day of menses, progressively lessens with menstrual flow. Investigations include pelvic sonography followed by CT or MRI scan if indicated, diagnostic hysterosalpingosonogram, sonosalpingography, endoscopy, diagnostic hysteroscopy or laparoscopy. Treatment includes counseling, psychotherapy to modify patient perception of her problem. Medical measures include analgesics such as paracetamol 500 mg TID, piroxicam 20 mg BID, antispasmodics like hyoscine, buscopan compound TID, anafortan TID, drotavirin TID, diclofenac TID. Prostaglandin synthesis inhibitors are cyclooxygenase inhibitors. NSAIDs such as mefenamic acid 250 to 500 mg QID provide relief in 80 to 90% of the cases. Indomethacin 25 mg 3 to 6 times daily provide relief in 70% of the cases. Naproxen, ketoprofen, ibuprofen are also effective. Glyceryl trinitrate GTN, a nitric oxide donor, relieves pain by relaxing smooth muscle of the uterus. Progestogen containing IUCD relieves pain in addition to providing contraceptive measure and reduce the bleeding. OC pills administered cyclically suppresses ovulation and are useful in relieving dysmenorrhea. Advantages are regularity of period, modest bleeding, desired contraception, makes this treatment of choice in many young women. The drugs also cure Mitchell's-Mertz pain. Pelvic endometriosis may be treated by increasing doses of danazole, OC pills, gonadotropin releasing hormone like leuprolide, buserelin, nafarelin. Vitamin E 200 mg BD starting 2 days before and 3 days during the periods claims to reduce the dysmenorrhea. Surgery is rarely undertaken if medical measures fail to provide relief and in women with secondary dysmenorrhea to treat the underlying pelvic pathology. Diagnostic hysteroscopy followed by dilatation and curettage, excision of the polyp or the uterine septum, dilatation of the cervix, it damages the nerves. Diagnostic laparoscopy followed by lysis of the pelvic adhesion, myomectomy, drainage of chocolate cyst, cautery, or laser vaporization of the island of endometriosis, excision of the adnexal masses, laser assisted uterosacral nerve ablation, LUNA for spasmodic dysmenorrhea, laparotomy followed by excision of chocolate cyst, eradication of endometriosis, myomectomy, excision of localized adenomyoma, presacral neurectomy, Cortis operation. Hysterectomy in elderly women is the last resort. Transcutaneous electrical nerve stimulation TENS is effective in 45% of the cases. Premenstrual syndrome PMS. It is also described as premenstrual tension, a symptom complex recognized primarily by cyclical changes associated with ovulatory cycles. It occurs 7 to 14 days prior to menstruation, resolves spontaneously after the menses. It is often accounted in middle-aged women. For two important reasons, it is important because symptoms of PMT are responsible for socio-economic loss. Secondly, because of associated legal and women rights issues that have arisen in conjunction with the personal accountability during the premenstrual period. Etiology. The exact cause of PMS is not known. It has been postulated that it represents a syndrome which is a result of multiple biochemical abnormalities. Estrogen excess or progesterone deficiency in the luteal phase, increased carbohydrate intolerance in the luteal phase, pyridoxine deficiency. This vitamin plays a role in estrogen synthesis and also in dopamine and serotonin production. Increased production of vasopressin, aldosterone, prolactin, systemic prostaglandin, which adversely affect renal function and contribute to fluid retention and bloating. Fluctuations in opiate peptide concentration affecting endorphin levels. However, biochemical estimations do not bear these out. At present, it is not clear whether PMS is an abnormal response to normal hormonal fluctuation or a result of hormonal abnormalities. Various symptoms of premenstrual tension are pain, headache, breast pain, abdominal cramp, muscle stiffness, backache, generalized body ache. Water retention symptoms like breast pain, bloating, weight gain. Behavioral changes like low performance, difficulty to concentrate, irritability, depression, forgetfulness, low judgment, anxiety, loneliness, feeling like crying. Autonomic changes like dizziness, faintness, nausea, vomiting, hot flushes. Diagnosis. It depends on the history and careful questioning. No pelvic lesion is detected and no definite test is available to confirm the diagnosis. Treatment. For psychological symptoms, counseling and reassurance alone is sufficient in milder cases. Vitamin B12 5 to 50 mcg, vitamin B6 100 mg, vitamin E 200 mg daily help in PMS cases. For breast symptoms alone, danazole 100 to 200 mg in divided doses during the luteal phase. However, adverse masculinization effect following long-term use is a drawback. GnRH analogs provide relief, but long use causes menopausal symptom and osteonecrosis. Gocirelin 3.6 mg subcutaneously 4 weekly, leuprolide acetate 3.75 mg IM 4 weekly, buserelin, triptorelin, bromocriptine are also effective. For bloatedness, weight gain, fluid retention and headache, salt and fluid restriction, spironolactone 100 mg and diuretics may help. Buspirone 7.5 to 15 mg daily or drospirenone may be used. Prostaglandin inhibitors like befenamic acid, naproxen improve mood and physical symptoms, but these drugs cause GI upset and rashes. COX inhibitor has fewer side effects than NSAID. Ibuprofen 400 mg 6 to 8 hourly is also helpful. Anxiolytic like alprazolam 0.5 mg and antidepressant tricyclics provide some relief from PMS. Gamma aminobutyric acid suppresses anxiety level in the brain. Therefore, GABA agonists are effective. SSRIs such as fluoxetine 20 mg daily, sertraline 50 mg have been beneficial in treating physical as well as behavioral symptoms. The side effects include headache, drowsiness, insomnia, sexual dysfunction, and GI disturbances. Sertraline and citalopram are also used in premenstrual phase. Vitamin B6, magnesium are cofactors in the synthesis of neurotransmitters serotonin and dopamine. 1 gram of calcium daily also helps to relieve the neurological symptom. OC pills render the cycle anovulatory and provide relief. Estrogen skin patch releasing 100 mcg daily or 50 mg estrogen implant with 100 mg testosterone is also employed. General measures such as exercise, relaxation, hobbies, meditation, yoga are likely to be beneficial. Mirena IUCD is now used instead of oral progestations.